tension between, let's say, a very senior doctor and maybe a healthcare worker is working, or health worker or nurse working directly with the patient, and understanding that when they're using an app, there might be some kind of pressure around surveillance in terms of how productive are they being, and having taken that into consideration when you're designing something that it won't make someone feel more vulnerable in a particular kind of work context.
We are actually very careful to intentionally design the system that it only exposes teamwork. It doesn't expose individual work to the manager because you don't want the system making it look like one of the healthcare workers is being unproductive. There's a whole lot of factors that the digital system's not capturing, right?
Mhm.
Nurse Mahima got assigned to the pharmacy for the whole morning. So she wasn't in front of the digital system. So it looks like she didn't do any work. But that doesn't mean she wasn't busy. It doesn't mean patients weren't being managed. It just means that the digital system isn't a holistic measurement of work in the clinic.
Data, once it's captured, doesn't have expiration. And so then it can be shared with someone else with a different intention. The immediate implication is how will I be surveilled and how will I be measured and qualified, as well as what happens next. Who else then demands access to that data set? Welcome to Unmissables, a podcast about how leaders in product, design, and technology are building what's next. I'm your host, Ariba Jahan, and let's get into it. What if the hardest part of product design wasn't designing the interface? It was actually infrastructure. What if success wasn't about delight or retention, but whether a nurse will use your tool on hour 11 of a 100-patient shift? The World Health Organization says that 129 countries now have national digital health strategies. Some of them are aiming to reach about 1 billion people. However, nearly half the world still lacks reliable internet. In many rural clinics, power outages are unpredictable and more common than you and I think. And then in India, a nurse might see 100 plus patients in one single day with just about 3 minutes per person as a best case scenario. So my guests today are the ones trying to figure out how do we close that gap? Not just with technology, but with better systems, infrastructures, collaborations, organization design across communities, institutions, governments, and clinicians on the ground. They are the co-founders of Hard Problems, Daniel Burka, Mahima Chandak, and Elyce Cole. Together, they're bringing design, product, and human psychology rigor to the messiest challenges in public health. So welcome to the podcast, guys. I want to start with the name. I love the audacity of calling your organization Hard Problems. It feels like a big challenge and call to action to the rest of the industry. Was there a specific moment where you looked at the landscape and said, the current way isn't working? Would love to hear what brought you all together to tackle this.
I mean, the original impetus for Hard Problems started 10 years ago. I worked at Google at the time. I was at Google's venture capital arm called GV. And I remember thinking every day I came into Google, I was remembering that you work at a huge advertising company. Of course, you're working on different products at Google, whether you're working on Chrome or Maps or News, or in my case, the venture capital arm. But fundamentally, you're working at a big ad company. If you walked around the halls at Google and you asked people, what are the big gnarly problems of the world? Even within Google, people would say things like climate change. They might say health outcomes. They might say things like income inequality. And then you look around your social network, your work network, and think, I know a lot of really talented people who are well paid, who could do kind of anything in their lives. How many of them work on the real problems of the world? And there were a few, don't get me wrong. Of course, there are a few great people like Dana Chisnell who are doing great work, but it's very few and far between, including myself. I was working at Google. And I thought it would be really interesting if we could, help more people to apply themselves to big, hard problems. I also thought it would be very Silicon Valley to roll out of a cush venture capital job and then be like, let's all change the world. So I left and joined a public health not-for-profit, and I was been working there for the last 8 years, a group called Resolve to Save Lives that's run by the former director of the Centers for Disease Control. So I feel like, having now worked in public health for 8 years, I have a little bit more sensibility about what it takes to succeed at working on some of the hard problems of the world. But more recently, Mahima, Elyce, and I have come back to this original idea from 10 years ago and thought, now seems like a good time to do this. How can we help more people in tech and design to go work on the real problems of the world, the really, really hard problem.
What about you guys? What made you excited and want to join this?
Yeah, I think I can give another perspective. I know Daniel was kind of working at a big organization when he was thinking about this. For me, it was, when I was studying design in college. I think when we go to design schools and we're formally trained, we think about some of these problems, but when we graduated and we went into the industry, you want to carry that idealism forward with you, but you see that nobody's really hiring designers for this kind of work. So a lot of my classmates ended up working with 10-minute delivery applications, right? And I think that gap was really big, wherein what we wanted to do when we were students, and then what we got to do when we got out. So that was my motivation to kind of start hard problems as well.
Less on the technical side, but more so on how do you kind of get non-tech related individuals to kind of align around certain goals or and kind of see the benefits of design, especially if people are operating with very different, like you said, kind of organizational contexts, cultures. But yeah, that oftentimes conflict is really related to like 80% of the time it's related to things like a lack of clarity around goals, roles, processes. It's not actually an interpersonal issue, but people often don't take the time to like step back and really think about that. So that's where I get energized in this space and supporting those multidisciplinary teams.
I love it. How do you three define hard problems?
Mahima and I have been both working on large public health projects, and the idea of health and suffering, people, no matter what your income background is, no matter where in the world you happen to be born, the fact that you get to live a longer, healthier life with your family, I think is, pretty easy to define as one of the gnarly problems of the world. The other area where we're particularly focused is climate change. I think if we think of the big risks to the world, climate change is an imminent risk. So I think if you look at something like the Sustainable Development Goals from the United Nations, I think that these types of frameworks that other people have already defined around what qualifies as a hard problem are good. I think, for us, it's really important that equity is a big part of the definition of a hard problem. These are the kinds of things that really do affect everyone on Earth, not just the people who have good health insurance, not just the people who can afford to pay for expensive therapies. So that's the other kind of really important defining characteristic.
Yeah, I think how can we use a technology and expertise that we know exists to fix that gap, right? Immediately makes me think about the prep chat we had. Daniel, I think you were reflecting on simple, and you said something that really stuck with me. We were talking about the impetus of like bringing digital and technology into the processes of a clinic. You talked about paper. We were just talking about like the state of AI right now. And I think I was just surprised by when you said paper is actually our competition and paper is pretty reliable. What was the brief of the project and how do you
For the last 8 years, I've been working on hypertension management, which sounds really basic. Hypertension is just a fancy word for high blood pressure. But hypertension alone is the biggest killer in the world. It is the leading indicator for cardiovascular disease, and heart attacks and strokes are by far and away the biggest killers in the world. If you can help more people to control their blood pressure in the world, you could save 100 million lives in the next 30 years. I happened to meet the former director of the Centers for Disease Control, Tom Frieden, when I was working at Google, and he had just started this not-for-profit with the goal of saving 100 million lives in 30 years. Do you do that with technology? No, you do this with big public health projects. So Resolve was set up to establish large hypertension control initiatives in big countries like India and China, Indonesia, Nigeria, Ethiopia. And to succeed, you have to do a whole bunch of public health things. So you need to do things like increase access to medicines, change treatment protocols so they're more accessible to people, do more patient-centered care, train thousands and thousands of healthcare workers. But fundamentally, you need a system of measurement. So I have to know, are patients getting healthier? And this means in hypertension management that you have to have a longitudinal record of every patient. And that's a hard thing to do at India scale. There's 200 million people in India, adults in India with hypertension. So what we started looking at doing is how can you record information about every patient at their visits in all these rural clinics all over India? And it's not just collecting data for data's sake. You're collecting data in order to drive feedback loops into the public health system, which means I can see which facilities are doing a good job of managing hypertension, which facilities are struggling, and then take the lessons from the good facilities and apply them to the weaker facilities and see if the numbers go up. So it's basic quality improvement, but applied at massive scale. And typically in clinics, all of this data is recorded on paper. And it's got two problems. One is that it's generally transactional data. So you only get, every patient looks like a new patient every time they visit, which is difficult for managing patients and difficult for getting kind of longitudinal data about how patients are managed over time. And it's also a very slow feedback loop. If I require facilities at the end of every month to compile their data and submit their data up to the next level, and then that data gets cleaned and then processed and handed up to the district level, and I get a report, say once a quarter, that says how are we doing as a health system, it's very, very slow. The advantage of a digital system is that you can reduce those feedback loops to like days or weeks. And so you can quickly say, oh, I did trainings, I saw a change in the numbers. Right? I'm looking at line, it's all line charts. But the challenge is those paper tools have been used for 50, 60 years and they work. They never run out of batteries. Everyone knows how they work. They, are robust systems that aren't finicky like digital tools. And so if your digital tool isn't ultra reliable and very quick, people will just fall back onto the paper tools that they're familiar with and that are reliable.
Another point I want to add that Daniel kind of raised was the word change. So oftentimes any type of kind of, new piece of tech that you're rolling out, you're essentially implementing a systems change. And so although everything that Daniel's describing seems very kind of obvious around kind of the benefits, the technical benefits of introducing a newer digital tool, but also speak to maybe the ways in which the existing tool is also useful, it's also helpful to think about what are these psychological or emotional investments that people have around any change, and how do you kind of do some research around that to see what are the barriers to adopting a new system or staying with the previous system. And all that's very unspoken. And I know oftentimes user research, that's their goal to kind of get in the weeds and sort that out. But just thinking about the kind of massive task of change management is really important with a lot of the issues that we're grappling with.
Speaking of change, actually, I remember when I joined the project, we had this behavior where our healthcare workers would use both their reliable paper system as well as our application, because they kind of didn't trust that the data just won't disappear from their mobile phone overnight. So there was like this, trying to have a backup with their paper systems. But I think at the end of the mark of fourth or fifth year, Daniel, we saw a complete behavior change where they were using the digital systems through and through for their record keeping. And I think that change element, is very important.
I mean, curious, what did you uncover through user research or including stakeholders, clinicians, or patients right into the design research process that allowed you to make some informed guesses of like, okay, this approach will create a behavior change, or this approach or this positioning will allow them to feel a level of trust, right?
This might sound a bit, fundamental for us coming from the tech world, but within public health, it's very rare to see people actually sit with users or nurses and understand their life and their constraints and design with them, right? So you'd be surprised. This was quite radical when we kind of proposed that we do this, when we started off simple. But it started with something as fundamentals, first principles in that way, which is you sit with them and you understand what does their workflow look like and where does technology even fit in, right? Because Daniel always says this, that nurses didn't come to use your app. They came to treat a patient. And we tend to think that our app is like the central and the hero and of the story, but it's really not, right? So once we sat with them, we started realizing that the number one thing that nurses told us was just don't make my life any harder. So the tech had to be out of their way completely. We made some key critical decisions early on, like the app having to work offline first, because internet is extremely patchy in some of these areas. And if you're relying on, there were a couple of applications even today, right? Like after 8 years of Simple, even today when I go to the field, I see that some applications just are web apps and they don't tend to work, right? And so there were some of these critical decisions about Simple that really helped it integrate well into the nurse's life. One of them, I think, was definitely going offline first, and we continue to take those lessons with other products that we build in India.
Yeah, I mean, What Mahim is saying is very true. I mean, a lot of observation in the clinics. So watching how people work. The biggest challenge is time in India. I think, Ariba, you said this in the introduction. There's approximately 3 minutes per patient is a typical clinical visit in India. Bangladesh, where we also work, is less than 2. So it's wild. Like, a lot of digital systems are designed in capital cities. So you're sitting in Delhi, or you're sitting in Dhaka, or you're sitting in London, where I am, and you're designing software for healthcare workers, but it's very easy to get disconnected from what's actually happening on the ground and thinking that it's totally reasonable to ask somebody to spend 60 seconds of a 2-minute patient visit doing data entry. This sounds really obvious, but it's a lot of health systems do this. They ask for huge amounts of data to very, very busy healthcare workers. And so what we did is we tried to cut down to the bare minimum how much data entry they need to do. And then all the data we did ask them to enter, we made it as efficient as possible. So the typical follow-up visit time in Simple is 13 seconds. So you can record an entire clinical visit, who this patient is, what their blood pressure is, what their current medicines are, what their blood glucose measures are, when their next follow-up visit is, 13 seconds median time. And this is done 1 million times a month right now. And so that was really key. And then you have to start looking, this is the real trick, is if you observe the work people are doing, you try to find things that they're spending a lot of time on currently. So the really great clinicians were spending several hours a week compiling overdue patient lists. So they were going through their paper records and saying, okay, all the patients who came last month, who hasn't come this month? And they would go through last month's register and then this month's register and, cross-correlate who's missing. They were great. And then they would spend hours calling those patients. As technologists, you look at this and you're like, that's actually a useful thing I can automate. They would also spend hours every month compiling the data and submitting it up to the district level. As a technologist, you look at that and you say, wow, that's something else I can automate. I can automate reports. I can automate overdue patient line lists for you. And all of a sudden, that's where they start appreciating the digital system, where it's buying them more time in the week to spend with their patients. That's when they stop disliking you and start offering their feedback on how to make the system better.
One of the questions I wanted to ask you guys is, what did you have to maybe bury because you were like, that's a cute idea. It is not something that's going to be valuable to these clinicians who actually have now told me that they need this, which might be more simpler technology, more invisible technology that supports a more service design approach. So Daniel, perfect segue to that co-design conversation of what you learned and implemented versus what you needed to walk away from.
When I talk to my old friends from Silicon Valley, the first things they think of are like the exciting new shiny technologies, right? Like, oh, okay, digital scribes. Like, why isn't the app auto recording as the clinician's talking and recording that data automatically into the EHR? Why aren't we using AI to do big data analysis against the data? And you're like, technologists can really get caught up in technology for technology's sake, right? And thinking that, oh, if we just throw more technology at this problem, we'll solve it. In reality, if you spend time in clinics, in India, it's really typical to have 6 or 7 patients in a room all together. That would be illegal in America based on HIPAA. In India, that's just common practice. There's no privacy for patients, and everyone's talking at the same time. And the idea that you could scribe that automatically into an EHR, I think, is a bit far-fetched. And plus, the benefit is quite low, right? The key is to ask for less data. If you ask for less data, even if you have to type the data, it doesn't take very long, right? And so we took the approach, instead of asking for maximal data, to ask for minimum data. What's the absolute least we can ask for a healthcare worker in order to get maximum benefit for the patient and for the overall health system? And so you kind of have to let go of the idea that you're making shiny technology. Like, we even thought about doing automatic blood pressure readings, because some blood pressure devices are Bluetooth enabled. And you just have to remember, like, how many times have you tried to connect to like a Bluetooth speaker and the frustration of trying to get them to pair, and the idea of asking a healthcare worker to like pair her mobile phone to the blood pressure device that's, 8 years old in her clinic in rural Punjab is like an unreasonable request for her. She didn't come to work to mess around with Bluetooth. She came to work to there's a line of patients already at her door, and giving her the pressure to kind of fiddle around with technology is kind of unreasonable.
I think another thought I was having was something around kind of unspoken power dynamics too. So I also did a bit of field work as well in the early days of Simple, and understanding tension between, let's say, a very senior doctor and maybe a healthcare worker who's working, or health worker or nurse working directly with the patient, and understanding that when they're using an app, there might be some kind of pressure around maybe surveillance in terms of how productive are they being, and having taken that into consideration when you're designing something that it won't make someone feel more vulnerable in a particular kind of work context.
And we were actually very careful to intentionally design the system that it only exposes teamwork. It doesn't expose individual work to the manager, because you don't want the system making it look like one of the healthcare workers is being unproductive. Because as we know, having observed a lot of care, there's a whole lot of factors that the digital system's not capturing, right? Nurse Mahima got assigned to the pharmacy for the whole morning, so she wasn't in front of the digital system. So it looks like she didn't do any work. But that doesn't mean she wasn't busy. It doesn't mean patients weren't being managed. It just means that the digital system isn't a holistic measurement of work in the clinic. Um, so we're very careful, fundamentally in how we design the system, that people wouldn't be punished based on their usage or non-usage of the system.
I think, Elyce, when you talked about the use of the data, it also made me think about how data, once it's captured, kind of doesn't have expiration. And so then it can be shared with someone else with a different intention. The immediate implication is, how will I be surveilled and how will I be measured and qualified, as well as what happens next? Who else then demands access to that data set? I just thought about government or other institutions that's like, well, we need to see whether this technology has improved efficiency at that rural clinic by X%. Only then will we implement it over here. And then suddenly you see standardizations or demands being made that's actually not responsible.
You wouldn't believe how much of the last 8 years were spent talking about data access, because this information, you're collecting private health information and basic demographic information about millions of people in countries around the world. And all of these countries have their own regulation about these issues and cultural issues. And so you have to be very careful as a steward of this amount of data, which is a fundamental design concern and not something you necessarily think about in a typical tech job. So there were a lot of discussions about, it's obviously government-owned data. We don't own the patient data. The governments own their own data, usually the Ministry of Health. And we, as the stewards of the technology, had to be extremely careful how we manage the data with the government and who got access to the information. And this leads to the really complex dynamics that you're not just building tools for healthcare workers and their patients, but you're also building tools for governments, state governments, national governments. And I've never appreciated before how much, when you're working on big systemic problems like public health and climate change, how much you're working at the political level. And I don't mean like the political level in Silicon Valley, like where people complain about office politics. I mean national governments and how they care about data. Like we worked in Ethiopia, which had a civil war while we were working there. We work in Sri Lanka, which went through bankruptcy. Bangladesh overthrew their government. So it's all of these things deeply impact your work in public health. Like it's not some abstraction. It's not an interesting thing that happened in that country. It has direct effects on how you design a system and how you get to implement that system in a country alongside the government.
It's not just the problem that you're trying to solve that's hard. Working in this domain with all the people, like there's a reason why these are hard problems, and figuring out how to navigate through the politics is one big area that's quite challenging in this world.
So within a multidisciplinary team, where you maybe have a head of design, head of engineering, head of public health, the tricky part, kind of to Mima's point, is the complexity of the problem requires everyone's expertise. And figuring out whose expertise to defer to at any given moment is just this constant kind of negotiation. And there's no map to it. Being very tuned and sensitive to that, and being humble. And as technologists, kind of humbling yourself and realizing there might be moments when I don't know something, and I might need to kind of not just lean on someone else's expertise, but actually even invite it in, because people naturally might want to default to the technologist in the room around a particular issue. And so I feel like with our work, we're very mindful of what we represent, professionally, maybe around nationality or maybe around socioeconomic class, gender, all of those representations or identities are in the room when you're working on very diverse teams.
So we're talking about co-design on the ground. How will this person use this? What are the features? What's the most minimal but supportive utility here to deliver them level? But also then, at least you're talking about co-design at a systems level, trust, and at a systems level where there's invisible and visible bureaucracies involved. What was it like to co-design with clinicians, patients, with whoever else you would qualify as your stakeholder on the ground level?
We observe the clinics a lot. We try to understand their workflows quite a bit. But then also, take the work that we were doing constantly to get feedback from the nurses as we were designing, getting them to also designing the study itself, designing the research itself, really find a way for them to contribute in terms of what exactly do they really require from that particular problem that we were trying to solve or that particular feature we were trying to build. So this was like an ongoing thing that we did on the field.
We did some direct, like exercises with a bunch of healthcare workers. Like, for instance, we were making like a progress feature, so you could see kind of how is my clinic doing, and it was great. We sat down with healthcare workers across a couple of states and asked them, what charts do you have on the wall that you measure your progress? Because they're like literally putting a big piece of paper on the wall and drawing like a chart of, how many patients did we have last month and how many patients did we have this month, that kind of thing. And we're like, oh, we can replicate that digitally. And then we asked them like, well, what are you proud of? And they're like, oh, I'm really proud that like how many patients I called or how many patients have lower blood pressure this month than they did last month. And we're able to build in that type of feedback. So when it's gamification in the good way, satisfying games do they already have going on in their heads? And then can we replicate some of that automatically in the software? And some of that worked really, really well in the end in order to kind of motivate healthcare workers to take the right actions with patients.
What if we go up a few levels and Elyce, coming back to you now with collaboration and trust building across ministry, government, policy changers, and where they want to support the new technologies and new solutions and approaches. How do you do that?
So the first thought that comes to mind is something about kind of everyone kind of unpicking the certain assumptions they have about whatever it is the problem that you're looking to solve, and really being clear that each group has the other person's group kind of interest in mind. And that it takes time to do that for various reasons. So I think just kind of pausing there, doing that work to kind of align around particular goals, and speak to any hidden agendas that might be at play is really important. And also maybe where people feel potentially at risk if a certain outcome isn't achieved, or just really understand what's at stake for each individual, their team, their organization, even their country can help.
I think a lot about how technology and technologists aren't the heroes in places like public health. In many ways, we're a service function, right? Like I was saying in the introduction, I think public health projects don't need technology. They need great public health. But great technology can be an enabler for them to succeed and an important function. And when you're working with stakeholders at the upper levels, so I'm talking about people at the Ministry of Health, people at places like the Indian Council of Medical Research, when you're working with these high-level people who are establishing the norms for public health programs, one of the good things you can do as a technologist is bring some of the methodology that we take as normal, things like agile development, things like prototyping, and use that in a supportive way to what they're doing. And it's really exciting when you're sitting with a government official and they're used to working in spreadsheets and in big standard operating procedures and memorandums and these very formal, very slow ways of communicating. And when they bring up a good idea, you're able to prototype it within a day or two and bring it back to them and say, hey, what I heard you saying in the meeting yesterday was this. And then all of a sudden they feel listened to and their input is garnered. And now you're all talking about a thing. To me, this is like one of the great powers of design and tech. The idea that we went from sitting in a big meeting room talking about abstractions to seeing a representation of what was discussed. So, hey, we're talking about drug stock management. Imagine we had a drug stock management platform that let us see trends of usage and predict future usage based on patient enrollment data. Well, it would look something like this. And all of a sudden, even if it's the wrong thing, people can see what it is and have a more robust discussion about it. And now tech is at the table in an important way, but also supporting the input from the more important, more powerful people in the room. And that really kind of establishes a stronger dynamic between the tech team and the kind of the big government people or the medical experts, where we can start kind of really collaborating more effectively together.
There was something else I want to add too. Oftentimes at the beginning of a project, I spend a lot of time just kind of digging into individuals or teams' history in relation to a particular problem that they're looking to solve. And so, in understanding that history, I can get a better sense of what might be informing their future decisions around a particular project. And so, understanding like what a project's history is in relation to tech. Have they had, good experiences, bad experiences? And really sitting with that, I think is really helpful too. So I just want to kind of add that bit around the importance of history.
Healthcare systems are extremely fragmented, right? I found a lot of value in using design thinking to highlight some of these problems where things are fragmented, bringing those problems into these rooms where government officials are trying to understand how to move the needle on disease care. And something Elyce was saying about, people in the room and motivations, I at least tend to look at them as a persona that I have to like understand, and try to see what their motivation is to then kind of bring alignment or influence the room.
I studied biomechanical engineering and then went into medicine for a while. I worked at a clinic that was a cardiothoracic clinic where all the patients were non-English speakers. And so I had to learn basic phrases like, oh, sumcha seyo. It was Korean of like, can you breathe? How's your breathing? How's your heart? Like basic triaging in order to make sure I can do that enough so that they can have trust. But then being able to measure really quick things in order to like keep them going because there was like so many patients coming in through the day. Contrasted with being in clinics as a med student inside hospitals where there's larger infrastructure, larger capacity, larger amounts of resources, you can spend more time with them. You can get into the nitty gritty of conversation. You are in a one-on-one room. So I think even within the US, there's a big contrast of experiences depending on resources made available or the infrastructures that are deployed, right? So I think there's a point at which you want to have your name against a project or a goal you've accomplished versus understanding that best case scenario, you'll make a dent here and you will make a dent only if you collaborate with others. How did you all, for yourself, switch perspectives or mindset? And how would you encourage other people to approach that mindset?
I was just having a conversation with a colleague last week, which I remembered, wherein even making a dent sometimes is hard, right? And these are difficult problems. You can work on them for years, but what we are used to in terms of progress or seeing the fast-paced environment in tech in terms of, outcomes, that does not have to always necessarily translate.
I mean, for me, the satisfaction is trying to solve something that no one solved before. And it's intoxicating, right? Like the design has been applied to many problems. And then you visit rural clinics in much of the world, including in America, and designers haven't worked on most of the problems there. And you look at that as a designer and you're like, wow, like there's maybe the most important area for design where you can genuinely impact people's lives. This isn't like Silicon Valley making a bunch of false promises about how you make people's lives better. If you can help someone have better care at their hospital, you're definitely making their lives better. And designers have barely touched these problems. And you can really positively impact people's lives. But as you were saying, it's going to take a long time to do it. Silicon Valley is really intoxicated with spending a year or two working on a problem and having impact. Pretty much all of the really hard problems of the world, public health, climate change, they're minimum decade-long problems to even make a dent. But you look at the people, to me, the people I really admire are people like Dana Chisnell, She's put 21 years into voting systems and making government systems in America better for citizens. That's inspiring. Somebody who could stick with a problem for that long, even though it's a slog, and show positive impact. I wish we had heroes like that in the tech world. Unfortunately, people like Dana are keeping their heads down, doing hard work, and often not getting the accolades because they're not running around on TikTok getting attention for it. But I do wish we could establish kind of a new culture in technology where we do admire the people who've put in a decade on a really gnarly problem and be able to move the number even a little bit. If you could help just 1% of people to have their blood pressure controlled more than today, you're talking about millions of lives saved. I mean, that's extraordinary. I thought about this when I first joined Resolve to Save Lives. The current devastation of heart attacks and strokes is just enormous. If you can reduce that devastation even a little bit, that's a remarkable thing to be a part of. And it's inspiring when you watch the public health people who've been doing it and keep doing the hard work. So to even just be a supporter to that mission, drives me. And it seems like we should be able to convince more tech people that that's a worthy mission, right?
Internally, we, talk about the analogy of beachheads when we try to think about how to bring on more people to work into this world. It's like a war analogy wherein when you're trying to conquer a new territory, you set up a beachhead, and then so that it's safe for other people to join you after, right? And if you think about it that way, what happened at Simple was that Daniel started working with some of the public health professionals, epidemiologists, making space for design, setting up the beachhead for me. And then I came on to join the project, and I continue to be, working on other public healthcare things right now. And now my aim is to set up beachheads for more people to bring them onto this world. And I think that's how we're kind of going to grow our army and get into this new territory. I think that's just generally a helpful analogy for us to think about in terms of creating a dent or not creating a dent. Maybe it's beyond that, right? Maybe it's beyond your project. Maybe it's making space for design in this world so that you leave a mark, even if you exit the project, but it continues to stay on.
I hope so. I mean, I guess that's what we're all here for. But so for me, what I get a lot of satisfaction in this space around both myself and trying to kind of encourage others to lean into more like nuance and complexity. And I think we have a healthy tension within our team around when do you embrace that nuance versus avoiding kind of, analysis paralysis. And so with a lot of these problems, there's no one, right answer. And so just really being explicit about what the trade-offs are and realizing that you're kind of making the best decision with imperfect information in a very kind of imperfect and very challenging context I think is the key.
For the listeners out there that's like, yes, I want to work on hard problems. What should they immediately try to build in their own skill sets, as well as where do they go? How do they enter the space?
First thing is just know it's not easy, right? So it's okay if you're struggling. There's not high paying jobs just sitting there with good, clear-cut job descriptions just waiting for you. If you want to work on hard problems, the first thing, we have a website called hardproblems.com. We do send out a newsletter at least once a month with a whole bunch of interesting jobs in it, as well as inspiration about how this career path could be open to you. So do that. We've also listed out on our website some of the great job sites that are listing jobs on problems like climate change and healthcare that could interest you in your area or remote jobs. So, you can search for those. And then we're going to start a podcast in the new year where we're going to start interviewing people who have been working on hard problems, especially designers and technologists. So come join our newsletter, keep your eyes posted for when we start doing that, and we'll try to expose you to more career paths that might be applicable to you. But we're just getting going, so I hope people can be a little patient as we start making these bridges more clear to people.
I'll also bring back an advice that Daniel himself gave me, which was that some of the best jobs out there might not have a job description listed out, right? It's maybe about meeting the people who are working on these problems. And that's how I'm currently working on an oral cancer project. And that door opened for me through a conversation, through demonstrating how design can help that particular project.
Mahima, actually, could you talk more about that project? I meant to ask about it earlier. I'd love to hear more.
Sure. The oral cancer, at least in, some of the Asian countries, right? I'll speak of India. It's a growing concern in India, a growing national concern. Out of the top 3 cancers that we have, breast, cervical, and oral cancer. And if you look at the global burden of oral cancer, India is also contributing 1/3 to the global burden, right? So like 33% of the cases worldwide come from India. And it's not just India as a country um, that has the problem of oral cancer. It's many other countries like Thailand or Vietnam, for instance. And these are all places where areca nut, which is a cash crop, which areca nut is like, it's used in the tobacco industry very extensively. It's a cash crop, it's grown, right? So the access to this carcinogenic fruit is readily available in your community. And when, you go to the field and talk to people, the reason why the habit is so strong of chewing areca nut is also because in a long day of labor, it gives you a little bit of a kick. It lets you work longer hours. It kills your hunger. And of course, you start really early. Like in India, it's culturally very accepted to give somebody, it's called supari in Hindi. It's very accepted to give that to some.
All my family, me and my uncles and aunts chew on shupari.
Yes. So, well, the problem starts from there. So it's like a really gnarly kind of a problem, because where do you stop this, right? The project I'm working on is early detection of oral cancer. What we can't have is specialists go to remote areas in India. It's also known as a poor man's disease because the prevalence is highest in the villages. What we can't have is a specialist or a dentist go to every, household to screen for oral cancer. But we do have a very extensive network of ASHA workers, nurses, mid-level health providers who do door-to-door screening for various other conditions. So the project I'm working on is an exploration on, can we just have a healthcare worker take about 8 to 10 images of somebody's oral cavity? And can AI help them understand whether this person needs to see a doctor or not? Right? So that first level of triaging is kind of what we're working on. And there are low risk cancers wherein if you catch them early, the quality of life increases. In some cases, if you stop the habit as well, it does not have to progress into a cancer. There are real challenges to actually implementing this successfully in the real world. For example, how do we do offline first, but with images, right? You need internet for all of this data to get synced. So making this work in the frontline is a real design challenge, if I can put it that way.
What's next for that project right now?
So we've so far validated that an AI model can work on images. What's next for the project is actually piloting AI at the edge, which means it runs on a smartphone, which is a low-cost device under, 10,000 rupees, like a low-end smartphone device that a healthcare worker who's probably a 10th pass can use, can kind of, AI help build her capacity over there. And what's next is we're going to kind of deploy that at the front line and see how it performs. So very early. It's a questions also about safe and ethical deployment of AI, right? In a context like healthcare and something like cancer, there are real ethical implications to kind of false diagnosing somebody. So trying to take those bits as individual problem statements that we need to kind of think about and do this ethically in the right way. So that's what's up ahead.
I mean, I love that you broke down the fact that it's not one problem. It's multiple problems strung together. So the ambition isn't we are going to solve oral cancer diagnostic problem, but it's more like how do we get just a little bit closer so that on a greater scale, we are helping people get diagnosed as early as possible so they can get the interventions as early as possible. So this podcast is called Unmissables, and oftentimes, we believe that some signals only become obvious, or some ways of thinking only become obvious once you've slowed down enough to really see them. So for you, what's the signal that you're seeing that maybe others are not noticing, and you want to call attention to that signal?
As an organizational psychologist who specializes in group dynamics, I think what came to mind was something around working horizontally, around collaboration, kind of people being very comfortable around not knowing and kind of task ambiguity, but also being able to authorize yourself in a space where it's just kind of unclear, what the landscape is like. And maybe who's leading a project, who's not, like just like something about kind of being comfortable operating that space and working, having fewer resources. So knowing how to advocate for yourself, how to get the resources on board that you need. So I feel that for individuals who are used to work in a very well-resourced, well-funded organization space where the project and goals are very clear, working on hard problems that you don't have any of those kind of protections. So just thinking about that seems really important.
The big thing I've been noticing over the last, I don't know, 5 or 6 years is a lot of designers who are disillusioned with design. When you talk to them, they're like, feel like their design has been corrupted by capitalism, that all they're doing is helping rich people to sell more stuff, or that design might have had a seat at the table, but what was the meaning of it? What was the purpose? And there's really two ways to go about this. You can either give up on design. And, I see people on LinkedIn who, say, oh, I'm retiring from design. I'm moving to Costa Rica and I'm going surfing. And lots of people are like clapping, like, good for you, getting out of the system. Then there's the other direction, like Don Norman's new book about, kind of the potential impact for good design, where you can go apply design to real problems and stop thinking about, how design can optimize corporations and think about how design can actually improve human lives, which is, as Mahima said, most of the reason why a lot of us got into design. In terms of like a pattern, I like that designers are more disillusioned. I like that we're starting to question, like, what are we applying our skills to? And is the just being paid a lot of money enough of a reason to do it? Are there other pathways? Are there other problems that we can apply design to that are worth our time? The answer is clearly yes. But we have to get out of our comfort zone. We have to go where there's maybe less money. We definitely have to go where there are less designers and go work on problems that actually matter in the world, that actually impact humanity. I really like the concept of ikigai, the Japanese concept of, applying yourself to good problems. A lot of us found things that we're good at, things that we can be paid for, and things we're passionate about. Very few of us found the fourth side of the ikigai kind of chart, which is things that the world actually needs. And I'm hoping that there's like a movement over the next decade of people who are applying themselves and applying their skills and their passion and their time to the big problems of the world, and that we can start celebrating those and maybe even change the culture of technology.
Yeah, I mean, I think the immediate thing that comes to mind is I think often it might feel like you have to quit making money and then go volunteer versus I think the reason hard problems exist is to create more functional and more pipelines to connect people apply their skills into paid employment. May not be the same level of paid employment but still paid, but applying to hard problems. And I think there's a huge trend of being fractional as well, right? So I think there's multi-hyphenated, there's portfolio careers, there's fractional roles. So I think if anyone's listening and they're like, well, I can't just quit my job, maybe it's not about quitting. Maybe it's about starting smaller of 10% of your time to a project that you really believe in. So, just throwing that caveat out there.
Or taking on clients who can't pay you as much money, but work at a design agency 26 years ago. And one of the things they do is they take on more interesting projects that maybe don't make them as much money as working for the Googles of the world. But like you look at their portfolio and like they've got to work on like internet access for disadvantaged Canadians, like real problems. If you don't just optimize for wealth, you get to do more interesting things.
Well, thank you so much for your time on this podcast. I've learned so much and I feel so inspired. And I'm ready to figure out which hard problem I'll get to dedicate some time to. Thanks for listening to Unmissables. If today's conversation sparked something new or made you think differently, subscribe to the show on Spotify, Apple Podcasts, or wherever you get your podcasts. And if you're enjoying the show, please consider leaving us a rating or review. It really helps more listeners find us. Unmissables has become bigger than the podcast now. I'm publishing deeper analysis, frameworks, and the signals I'm paying attention to over on Substack. You can find all of it at unmissables.xyz. See you on the next episode.